Great. So good afternoon, everyone, and welcome. This is Najla Nasri from Johns Hopkins, and I'll be moderating our journal club session. We're fortunate today to have Dr. Craig Gunderson with us. He'll be presenting a manuscript that he published in the BMJ this spring called Prevalence of Harmful Diagnostic Errors in Hospitalized Adults, a Systematic Review and Meta-Analysis. It's a very interesting paper, and it'll be a great session today, so thank you all for joining us. So I'd like to introduce today's Journal Club speaker, Dr. Craig Gunderson. Dr. Gunderson is an associate professor of medicine at Yale University School of Medicine. He graduated from Harvard Medical School and completed a residency and chief year at Yale. He's currently the associate firm chief and section chief of hospital medicine in the VA Connecticut Healthcare System. Dr. Gunderson is also the chair of the National VA Hospital Medicine Executive Council. His research interests have been in patient safety, in particular common infections in hospitalized patients, and in systematic review methodology. Welcome, Dr. Gunderson, and thank you for presenting today. We'll turn over the slides to you.
Thank you. I think because of the VA firewall, Vanessa has been nice enough to take over slide forwarding, so she's going to get our slides up here. That looks good. So prevalence of harmful diagnostic errors in hospitalized adults, a systematic review and meta-analysis. And I'll say before we kick in that having authored a number of these, that it was really nice for me that when this got, I guess, first published online, that very soon afterwards I got emails from Dr. Newman Toker and Dr. Graber expressing interest in the topic, and I think inviting me to present to you guys. And it's very nice for systematic reviewers. We spend usually a year with these topics, and we get to know the topics very well, sometimes too well by the time the project is actually published and stuff. And anyway, it was really nice to be invited to speak, so I'm looking forward to it. And Vanessa, you can go ahead to the first slide, or second. So by way of introduction, diagnostic errors, of course, are one of the classic types of adverse events described in the literature. And several commentators authors have commented that compared to other types of adverse events, such as, say, diagnostic errors or procedure-related errors, that diagnostic errors have received relatively little attention. And you've probably all heard this before, and I completely agree. And we noticed in looking at the literature related to diagnostic error that a couple sort of basic questions had not been systematically reviewed, including the prevalence of diagnostic error in hospitalized patients, and also a systematic review relating to what are the range of actual diagnoses that are being missed. So next slide. So that basically beget our two questions. What proportion of hospitalized patients have an associated diagnostic error? And what diagnoses are we actually missing? Next slide. So our study methods, a lot on this slide, but basically it's more or less the same as any systematic review. We started with a electronic search, and we used Medline, Embase, the Web of Science, and the Cochrane Library. And we were looking for studies of hospitalized adults that used physician reviews and reported a frequency or a rate of diagnostic error, basically. Because we had an epidemiologic question, we primarily were looking for studies that were relatively unselected, so patients that were consecutive or randomly selected cohorts. We also included studies that had selection criteria, such as ICU patients only, but analyzed those separately. We excluded studies that didn't use physician review to determine diagnostic errors, such as surveys. We saw a number of surveys in the literature. And we also excluded studies that were limited to specific populations like peds or outpatients, or studies with a single diagnosis like tuberculosis, for example. Then ultimately, two authors screened all the studies for inclusion or exclusion. We did the standard study quality assessment using a standardized checklist, essentially. And then for the diagnostic error rate, the individual study rates were averaged or pooled using random effects meta-analysis, and the variation in the individual studies was described in a standard way using something called an I-square statistic. And then because we figured with observational research there would be variation, we had pre-specified subgroups for subgroup analysis and sort of a fancy form of subgroup analysis, which is called meta-regression, which I'll show you later on. We can go to the next slide. So figure 1 for our results, the study selection flow diagram. As you can basically see, we started with about 8,000 titles and abstracts and look through all those. Oop. Automatic light. Started with about 8,000 titles and abstracts, looked through those, resulted in 220 full manuscripts for review, and then ultimately 46 studies that we included or met study inclusion criteria. Next slide. And if you look at those 46 studies, it was about half and half. 24 of them were random or consecutively selected patients. And of those, 22 were appropriate for meta-analysis. And then another 22, as it turned out, studies had some sort of selection criteria, and those were, as I mentioned, analyzed qualitatively. Next slide. So this is just a slide of what the tables look like. Usually the first table in a systematic review is just a description of the included studies, but we had so many and there was enough, they were complicated enough. There were multiple supplementary files, which I really hate to do, but there's no other way to do it. But just to describe the studies that were in the meta-analysis portion of the study, they basically ranged in years from 1995 to 2018. They were from throughout the world, basically very geographically diverse, although sort of skewed away from North America. I think there's 2 studies from the US and 2 from Canada. The typical study of these was a multi-center study, and many of them were intended or meant to be basically representative of the population or the country that it came from. So there are multiple hospitals with many patients. And the actual methods for the studies was very similar if you're familiar with the Harvard Medical Practice Study, which was a study of adverse events from New York in the 1980s that was published in the early 90s. And I think actually the next slide has a slide on the basic methods from that. So we can go to the next slide. Yeah, there you go. So basically, all these studies adopted what I call the Harvard Medical Practice method. So it starts with a series of admissions, and then nurses review the charts for the occurrence of certain criteria for the Harvard Medical Practice Study. There were 16, I believe. Things like ICU transfer, blood transfusion, or readmission or death, or those kind of things. And charts that were reviewed positive were then reviewed by physicians for step 2. And for most of these studies, they used a Likert scale, a 6-point Likert scale, to determine whether an adverse event occurred. And adverse events were, I think, all defined as harm due to the patient, due to the healthcare, rather than the underlying disease. And once the physicians determined whether an adverse event had occurred, they were then, for step 3, categorized into the type of adverse event, whether it was medication or procedure-related, or, of course, diagnostic error. Next slide. So all these studies basically, which was a nice thing for somebody who does meta-analysis, you want to have studies that are very similar. If you're combining them, they all basically follow the Harvard Medical Practice methods, but there was some variation, and this is where systematic reviewers get a little, get really into the weeds, as they say. It's very important potentially for understanding the results of the study. So for the way I broke it up, for the first step for the nursing screening criteria, almost all the studies use criteria, 21 out of the 24 that were based on the Harvard Medical Practice Study, but 3 of them use other types of criteria. And for the second step, 19 of the studies used the famous 6-point Likert scale for whether an adverse event had occurred. The others just use yes, no, whether an adverse event had occurred. And then for the third step, dividing the types of adverse events into categories, there was actually probably even more variety. They all, of course, included diagnostic error as a category, and I think they all included medication error and procedures. But beyond that, there was a fair amount of variation, and as you can see, there was between 4 and 10 categories. So that was probably the step that had the most amount of variation, which I'll get back to later. And then in other important areas of variation were all the studies used the same definition ostensibly of adverse event, which was harm due to the patient, due to medication, due to medical care rather than underlying disease. But they defined harm somewhat differently, and a lot of the older studies basically used what I called a restrictive definition, which is, I put it there on the slide, prolonged length of stay, death, or disability at discharge, which when you think about it is a pretty limited definition of adverse event. Someone could have an adverse event which had resolved a week later by the time they were discharged, and that actually, strictly speaking, would not have been counted. I think most of the more recent studies used a relatively more permissive definition of harm. And then lastly, there's important, almost all these studies included events prior to admission in some way, but not all of them did. And then about half the studies included in some way events after admission, but again, not half of all of them. So next slide. Last 2 points about the study. So obviously, to summarize, there's sort of a complex multi-stage process to determine whether diagnostic error had occurred. And also, since all the diagnostic errors were defined as types of adverse event, they all require patient harm. So technically, our review relates to harmful diagnostic errors, which potentially may not include all diagnostic errors. Next slide. And so that was related to the studies in the meta-analysis. The studies that had selection criteria, you can just go to the next slide. These obviously were actually fairly similar to the other studies, except obviously they had selection criteria, limited to surgery-only patients, internal medicine-only patients, number limited only to ICU patients, etc. But they were similarly varied geographically. About half of them used the two-step process with nurse screening. The other half reviewed all the case series of admissions. Most of the ones that had the two-step process were similar to the Harvard Medical Practice study again. About half used the Likert scale for adverse event. The rest just used yes/no determination. And then only about a third of it included events prior to the admission. The rest either didn't report it or actually stated that they did not include those. You can go forward, I think, another one. Okay, yeah. Well, actually, you can stay on this. So one of the hearts of one of the several hearts of a systematic review is trying to get, besides describing the studies, but is basically evaluating the so-called quality of the included studies, or now it's typically called risk of bias. And we used a standard checklist for these kind of studies for risk of bias, and we found basically that all of the included studies had some important limitation. And the biggest one actually is what is called representativeness, or generalizability, you might think of it. And you can see that with the studies that had selection criteria. Obviously, patients that are admitted to surgery are not necessarily generalizable to all hospitalized patients or ICU patients, et cetera. But even the studies that were in the meta-analysis that started out as consecutive case series of admissions, because they used nursing screening criteria, and only on average about a third of patients had one of those criteria, it ended up with a selected group of patients to actually review for diagnostic error. So there's nothing wrong with that per se, but for using it for a prevalence study, epidemiologically, it obviously has limitations. So all the studies lost a little point on that one. And then only a third, or a little more than a third of studies met our criteria for objective standards for defining adverse event and diagnostic error. Only about half met the criteria for reviewer training, and many of the studies that had selection criteria were relatively small and didn't meet the criteria for sample size. Next slide. Okay, so that's what I have to say on the description of the studies. as I said, for systematic reviews, it's a lot, but that's really an overlooked part of systematic reviews. This is the forest plot of the 22 studies that ended up in the meta-analysis for the rate of diagnostic error. And you can see that the individual study rates varied substantially from 0.1%, I think was the least, to 2.7%. And so ideally you want a forest plot to look like a telephone pole, I tell people, rather than a double helix. So it's kind of a little all over the place. But when that gets pooled, the pooled rate or average rate for diagnostic error was 0.7% with a 95% confidence interval between 0.5 and 1.1%. And if you multiply 0.7% times the number of admissions to the hospitals in the United States yearly, the number is 250,000 diagnostic errors occurring, harmful diagnostic errors occurring yearly in the United States. Next slide. A couple comments. Again, only harmful diagnostic errors. Big caveat for this is that because only a selected number of charts, only the screen positive charts were actually reviewed for diagnostic error, this actually is technically the minimum rate that we found based on the literature, because undoubtedly some of the charts that weren't reviewed, just because they didn't get transferred to an ICU or get a blood transfusion, would not necessarily immunize them from having a diagnostic error. Forgot about my automatic light in my office. Very environmental up here. The studies that had selection criteria, by and large, had probably even more varied rates. Most of them that had high-risk selection criteria, such as ICU transfer, et cetera, had higher rates of diagnostic error. Our rate that we found, 0.7%, is lower than is typically cited in the literature. Most commonly, you see between 5 and 10% of diagnoses cited as considered to be erroneous. I would say our rate is different for several reasons, besides that it's based on a specific type of literature. But reasons that it might be lower, again, is that, as I said, only about a third of the charts were actually included ultimately in the physician review. And of course, these are retrospective reviews of charts, and unknown but undoubtedly important information related to diagnosis, especially related to prior outpatient diagnoses, would not necessarily be in the chart. And there was other potential biases related to chart reviews. Next slide. A quick mention about heterogeneity. So as I mentioned before, you can see a lot of variation in individual study rates. That can be mathematically described by something called an I-square statistic. It basically just means that there is a lot of variation. The eyeball test worked pretty well for this too. And a lot of people see that as a weakness in meta-analysis. It actually is not necessarily. It can actually, if you can explain it, potentially adds information to your study. And what you can do is do study level variables and see if those explain the amount of variation. And when we did that, we found that 35% of the variation was just due to the location of the studies. And namely, studies outside of Europe and North America reported higher rates of diagnostic error, about twice the rate, if I remember correctly, than studies in North America and Europe. Facilities, about 65% of the variation is unexplained. We also divided the 3 steps and looked at the variation across those three steps. And actually, at the time, I was surprised. It makes sense now that I've had time to think about it. But half the variation was in that last step, where the adverse event was divided into subtypes. And that's probably not surprising in retrospect, because as I mentioned, a lot of those studies, that information would be on Table 5. It wasn't necessarily the main point of the purpose of the study, which is more related to adverse events. And there was a lot of relative rigor about the first 2 steps in terms of having specific nursing criteria and training, and also physician training related to adverse event and Likert scale determination, et cetera. And then I think the categorizing the types of adverse event was a little more on the back of the envelope, I would say. Next step. This is what a subgroup analysis might look like. And just my point here is that we looked at a lot of different variables, and none of them really made much of a difference for heterogeneity or the overall rate of diagnostic error. So whether it was a single hospital, multiple hospital, differences in whether certain types of patients were excluded, the overall study quality, the definition, variations on the definitions that were used, et cetera. The only variable really made much of a difference was the study location. Next slide. That's a little overzealous subgroup analysis, by the way, if there's systematic reviewers out there. Okay, so that's all I'm going to say about the rate of diagnostic error now. The other question we really had, and one of the main reasons we undertook this this undertaking, was we were hopeful that we'd get a nice list of what diagnoses were commonly missing, basically. And if you just look at the 22 studies in the forest plot, that was about, I think the total was about 800 diagnostic errors that were counted. But unfortunately, most of the studies, I think it was only about 5 or 6, actually described what the diagnostic errors were. Mostly just studies counted them, unfortunately. So the total number of diagnoses that we tabulated with all those studies was only 136. And then what I did was made this table based on diagnoses that were described more than once, to kind of give some idea of what the more common misdiagnoses were. You can see the most common one were cancer diagnoses. And in particular, to my surprise, the number one cancer in our sample, at least, was colorectal cancer, which I thought was interesting. Then other diagnoses, you can see pulmonary embolism, which is one of our favorites in internal medicine. Aortic aneurysm, another one of our favorites to discuss about for misdiagnosis in particular. Presumably they mean symptomatic aortic aneurysm. Congestive heart failure, a little surprise to me. Urinary tract infection. Gastrointestinal perforation, I'm a little surprised, but those mostly are on surgical service. Sepsis, small bowel obstruction, appendicitis. I cheated a little bit and made a combined CNS category for subarachnoid hemorrhage, subdural hemorrhage, and CNS Mets. Just because I think it's an important category. We spent a lot of time worried about skeletal fracture, acute coronary syndrome, alcohol use disorder, and delirium rounds out the list. And if you tabulate all those, that's about half of the total misdiagnoses were those 14 categories. Next slide. Hopefully not a list. So just comments on the list of diagnostic errors. One, I would just say that I thought was interesting when I finally got around and made that slide, is that when I look at that, I realized I had either personally made or had relatively vivid memories of almost every one of the entities on that list. And I thought that was really interesting. And it made me think of cases I had kind of not really thought about, but even going back to medical school, when the first I didn't actually have the term diagnostic error in my my mind at the time, but the first one I can remember was when I was a third-year medical student. So I thought that was very interesting, and most of the entities or diagnoses on that list were already or have been previously associated with diagnostic error. It was very easy to find references for me to reference all those missed or delayed diagnoses. I was struck that most of them were relatively common bread and butter subjects or diagnoses, or diseases, I should say. It wasn't like we were missing vasculitis or obscure causes of FUO or something. You couldn't come up with to a certain extent, more mundane list. And I thought it was a mix of diagnoses that would seem, at least superficially, to be straightforward, like something like small bowel obstruction or delirium, which is basically a bedside diagnosis. With diagnoses that are actually kind of have a reputation or known to be a little more obscure, such as a symptomatic aneurysm, potentially appendicitis, especially if CT is not easily available, and of course pulmonary embolism as well. Next slide. So major strengths of our study was the first systematic review to assess the rate of diagnostic error and attempt to describe the range of misdiagnoses. I do believe it's the best estimate of the true rate based on the current literature, but with the caveat that there were, as I said, major limitations in the literature. Major limitations for our study. Studies all obviously use physician review to determine adverse events. and diagnostic errors, which is, of course, subject to bias. Certainly has imperfect inter-rater agreement, and of course, for retrospective studies in particular, may be subject to missing data. Other weakness, as I mentioned, all these studies, at least weakness epidemiologically, is they use nursing screening criteria. So for our purposes, basically that means we assume that screen negative charts were without diagnostic error, which, as I mentioned, is undoubtedly not true. So as I said, this is the minimum rate. And of course, we did have high heterogeneity or variation in individual study rates, which is not surprising at all with a complex question with sort of a complex methodology to determine it. And most of these studies, I said, were really primarily designed for adverse event, and the description or categories were a little more secondary to their main purpose. Next slide. So for our bottom line, based on physician review, at least 0.7% of hospitalized patients experience a diagnostic error. In the US, this would be about 250,000 misdiagnoses annually. A wide range of diseases are missed, including many common diseases. Although based on a limited sample size, 14 categories or diagnoses accounted for about half the misdiagnoses. I think the fact that common diagnoses are missed implies that improving diagnosis needs to involve improving the basic clinical process of diagnosis. Thank you. I have one more slide for my acknowledgments. You can see my colleagues, my co-authors. Thank you.
Thank you, Dr. Gunderson.
Sure.
We'll open up the floor for your questions or comments, and feel free to unmute or leave any comments on your phone.
This is Dave Newman-Tokert. Thanks so much, Craig. Really appreciate it. This is a great presentation. It's a great study. Couple of quick questions for you. I gather that when you say diagnostic errors here, you mean diagnostic adverse events or some sort of misdiagnosis-related harms rather than diagnostic errors per se, right?
Yeah, they would all be subtypes of adverse event that implied harm. So diagnostic adverse events or harmful diagnostic. I think we tended to use harmful diagnostic errors as our term.
So in terms of the severity of those harms, could you just talk a little bit about sort of serious harms, that is death and permanent disability type stuff, versus less serious harms? Overall, what was your gestalt about that? Because I didn't see a lot about that in the paper.
Yeah, that was like all the emails I got were asking me, well, how many deaths were due to these and stuff? And we actually didn't think of that. And our prior paper we did just before this was actually related to preventable deaths in hospitalized patients. So it's kind of too bad we didn't. And all I can say is that, as I mentioned, all the included studies used had definitions of adverse event that included patient harm, as I mentioned. I can't remember the number. I think it was 7 or 8 of the studies had that more restricted definition that involved prolonged length of stay, death, or persistent disability at the time of discharge. And then the ones after that just said harm. So unfortunately, I didn't look at that. And it'd be interesting to know what exactly the magnitude of harm was from all these diagnostic errors.
I mean, we could sort of guess at it from, say, Laura Swan's study, for instance, which suggested, I think, about 45% of the harms were at that sort of higher end seriousness in the hospital. But sounds like you guys didn't specifically gather data on that point.
No, we didn't at all.
One other quick question that I want to let other people ask. You talked a little bit about there not being a reflection of diagnostic errors that happened for the most part, in the pre-hospital setting. There were some that dealt with pre-hospital emergency care, but that for the most part, it was diagnoses that were happening in the hospital. Could you just clarify, to the extent that you recall the details, sort of where most of these diagnostic errors were happening? Were they happening Did any of the studies report whether, for instance, they were only restricting themselves to things that happened while the patient was an inpatient, or whether they included emergency department misdiagnoses antecedent to a hospitalization that were discovered during the hospitalization? Like
Yeah.
how far did you have to go before it was a diagnostic? Like, did you have to get all the way to a discharge before it was a diagnostic error? And if so, where along that pathway were things not counted as diagnostic errors?
Yeah. So you hit on both my weaknesses, I guess. You're good. You're doing that on purpose now. The we actually, most of the studies didn't actually give that information. The vast majority, I think a few did. I did most of this work 6 months ago. The data extraction stuff. A few of the studies gave a breakdown, and I want to say something like a quarter of that one study reported that the diagnostic error had occurred prior to the admission, as opposed to the 3/4 that occurred to within the hospital. But the vast majority just didn't actually report that information, and we didn't look at it carefully enough. So, but that's one of the reasons I'm kind of happy that you guys asked me to present, because that gives me two ideas for more further review of the literature that I now know really well. It'd be interesting what's the timing and also what's the range of harms that occur with diagnostic errors.
Awesome. Thank you. Appreciate that.
Dr. Gunderson, I had a clarifying question. In that figure where you display the 14 most common conditions that were associated with harm, did that population also include pediatrics? Because there were some studies that also included pediatric patients, or is that only focusing in on the adult in the cohort?
Yeah, I could go back and look at that table to see. One of the subgroup would tell you how many studies actually had some inclusion of pediatrics, but it was all very small amounts. It was like 1 or 2% typically of pediatric patients. So my guess is the vast majority of those diagnostic errors were going to be adult, probably 98% of them, if not all of them, unfortunately. Fortunately or unfortunately.
Hmm.
Well, if others aren't going to ask while they're cogitating on their questions, I'll ask one more. Could you give us your speculation on the cancer misdiagnosis issue? Typically, one thinks of that disproportionately, and at least in malpractice claims, is disproportionately something that happens in the primary care or clinic type setting, as opposed to an inpatient hospitalization. Do you have any sense for whether those were just intra-hospital delays in diagnosis? Like they started off with not realizing it was, they thought it was something else. They thought the patient had a UTI, and then they realized, 5 days later that it was cancer. Or were these counting cases from prior to the hospitalization? Do you have any sense for the specific things around cancer misdiagnosis that could help us understand the reason why that was so high, so to speak, on your?
Yeah, unfortunately, there's little information. The actual diagnoses, these were like buried in the supplements on 5 of the 46 studies or whatever. Most of them really, for whatever reason, I thought it was interesting, just didn't think to actually list what the diagnostic errors were. And when they did, they didn't give details. It's just a list. But my guess would be, is just exactly as you mentioned, it would be almost all the studies, as I said, included events prior to admission. So somehow it probably became aware to the reviewer. My guess on most of these is that the patient had presented to their primary care doctor with some complaint and that had been sent home and then presented in worsened straits and got hospitalized and was found to have malignancy. I don't know that because, again, the descriptions aren't there, but that was the scenario I had in my mind. So patients that were told they had irritable bowel syndrome and then develop worsening abdominal pain and go to the ER and get are jaundiced and found to have pancreatic cancer or something along those lines. Which is certainly something we see I see myself in our hospital, not uncommonly. And I thought it was interesting. Cancer is the number one diagnostic category. Is probably not surprising. Cancers are obviously common, and also I think there's probably a little bit of less tolerance for a quote-unquote delayed diagnosis in cancer. It was interesting. Colorectal cancer was the number one particular diagnosis, and I never would have guessed that because to me, that's maybe not the most straightforward malignancy to diagnose, but basically iron deficiency anemia is colon cancer until proven otherwise, etc. And I actually had not appreciated how much literature there was in the GI literature about missed diagnosis of colon cancer, endoscopically, I mean. And then there is also a lot of literature. It's not quite something you would typically call perhaps a diagnostic error, but in delayed diagnosis of colorectal cancer related to social determinants of care and certain qualities related to primary care and shared decision making. So there's actually a lot of literature. I don't know if anybody on the call is aware of that. I never would have known that. I thought that was very interesting finding. The other thing I noticed about the malignancies that's perhaps not surprising, but I can't remember the numbers off the top of my head. I think it is in the paper, but I think it was either 9 or 11 of the 15 were GI malignancies. And that in some ways doesn't surprise me because a lot of those are known to be luminal diagnoses. So esophageal cancer, gastric cancer, I think there was a cholangio. I think there was at least one pancreatic cancer in there. And then there was a variety of others as well. So
just one thing you said I was a little confused about. You said, this time you said almost all included events prior to admission, but before I thought you said 25%, or only a few studies included whether it was before or after.
Oh, sorry. Yeah, 21 of the 24, I think, included events prior to admission in some way. And then
but only give a breakdown.
The breakdown, it was only one or two that I can remember. And again, I didn't think to look at that very closely, though. So don't hold me to it. But that's my impression.
Got it. Thank you.
And I see a comment about colorectal cancer from Dr. Singh, missed in about a third, I guess, of cases of colorectal cancer. It's been missed in some way. So there you have it. So that's very interesting to me. Not somebody who comes from a background about someone who's interested in diagnostic error, but I've not done research in the area. I thought that was very interesting. I learned a lot. And I thought, again, I was struck by, I would have really thought rare diagnoses would be, now granted they're rare, so they're not going to necessarily show up on a representative sample, so it may just be that. But I was impressed by how many of these are bread and butter diagnoses that we see all day. I guess I shouldn't be surprised, but I thought that was impressive.
Vanessa, would you be able to unmute John? He has a comment, and I think after him, Laura had a comment.
Okay.
And Vanessa, if you can't unmute them selectively, you can just unmute everybody if that's the easier way. But I suspect there are people with questions beyond me, and it may just be that they can't speak up.
Right, and I am trying to unmute everyone.
I can unmute myself. I can go first while you try to figure out how to unmute John, if that's okay.
I found him, yes.
Go ahead.
Yeah, all right. Also, thank you, Greg, for a great presentation. I wanted to follow up on some of David's questions. Indeed, some of my studies included in this review from the Netherlands, and we found indeed that the diagnostic errors are more harmful than other adverse events types, and I think that's it was the same for our follow-up studies in the Netherlands as well. Not sure about studies from other countries or other settings. And regarding the timing of the measurement, what was included, I think most of those studies have like a 1 year, they review the records 1 year before an index admission and 1 year after an index admission. And in my specific studies, we found that most of the diagnostic errors were identified in a subsequent hospital admission. So that might add some to the conversation. I also wanted to let you know that Hardeep and I have written an editorial on this paper, so it should be coming out soon. And we thought it was a great study, and we reflected some of these things that you have said about the lower rates of diagnostic errors in comparison to other studies in our field, especially indeed because of the adverse event focus, but also we've seen some studies in which diagnostic errors are classified as other error types in these studies because it measures not only diagnostic errors usually. So we have some reflections on that, and it should be coming out soon too.
Thank you very much for your comments, and I can't wait to see your editorial. That's very nice. It's very interesting for me to talk to people that I've only referenced in all their papers. If that's Laura's one, I assume.
Yes, yes.
That's great. Nice to meet you.
Nice to meet you.
I look forward to the editorial.
We'll send it to you, or you'll see it coming up soon.
And I thought it was amusing. I got a bunch of emails from this group in some way, totally with the same questions, the same deficits that David mentioned in terms of related to what were the harms, how many deaths, et cetera, like that. I think they may have been in reviewer comments too. So maybe the next paper.
Yeah. Thank you.
John, did you have a question?
I did. I'm not sure if I'm unmuted. Am I unmuted?
Yes.
You're good, John.
Okay. I wondered if any of the studies you looked at divided errors based on, or grouped errors based on whether they were preventable or not, or blameworthy, or, for example, fault versus no fault. I mean, there are lots of ways you can describe this, but a no fault error might be one that where the disease presented atypically, or was exceedingly rare, or presented when it was really too early to be diagnosed by any competent physician, versus those where there was really a clear fault or clearly preventable.
Yes, as a matter of fact, a lot of the studies made a distinction between preventable diagnostic errors and those that they felt were apparently unpreventable in some way. And we had to put in our original protocol that we were going to use the numbers for preventable diagnostic error, if I remember correctly. And then I went back and checked, and the vast majority of the diagnostic errors that were identified were also coded as preventable. So it made no difference in our overall rate. That much I remember. Almost all of them use the term, as you mentioned, preventable. The Harvard Medical Practice Studies, you probably remember, also, instead of preventable, talked about negligence, which is more the medical legal idea. And I don't remember probably they did distinguish between adverse events and diagnostic errors that were due to negligence or not, but I didn't remember that. And that particular study was not in the meta-analysis because they had some things they did with the sampling. Actually, they oversampled certain diagnoses. So being the stickler that I am for meta-analysis, they actually didn't get included. But yeah, absolutely, the preventable was a note for a number of the studies. Not as many as you think. I think a lot of the earlier studies is my sense, and then after a while, people just decided that enough of diagnostic errors, since it would appear that the vast majority would also be judged to be preventable, they just dropped the distinction, is my impression. I didn't look at it very closely, though.
Can I just
to follow up?
Oh, go ahead, John.
Just to follow up briefly on, I say briefly, this is sort of a loaded question, but and it does not have anything directly to do with your paper. So if you want to not answer it, that's fine. But I just wondered if, based on this study or your own experience, if you have a sense of, since the ultimate goal is to prevent diagnostic errors, and I'll limit it to inpatient errors since that's your area, if you have any take-home messages from your own experience or from the studies you reviewed about, if you could give me a list of 3 things that I could do to prevent diagnostic errors in my own practice or in your own practice, what would you do?
That's a great question. I thought about that a little bit. I'm involved in medical education a lot, so I thought this was such an interesting topic for me, and so I think about it with the residents in particular, and I don't know, off the top of my head, I tend to thinking back about myself when I was younger and less experienced, how important experience is. I remember what I was like as a resident, for example, and I read all the time and I memorized differentials all day. I literally spent time just memorizing differentials all the time. But I think I'm a much better diagnostician now, and I've forgotten half of those differentials, I would say, or at least some fraction of them. So I think experience is really important. I hate to say that, but I'm pretty sure errors or diagnoses that I've been surprised by or have been made errors in, I'm pretty sure I'm less likely. I could make them again, knowing myself, but I think I'm less likely to. And I see that with the young doctors I work with a lot. And sometimes I see things that are so obvious, it amazes me that they didn't notice that, for example, the patient with fever that they admitted with pneumonia can't actually move their knee, for example, because they have septic arthritis. So I think experience is obvious. And then I think another one is obviously in the hospitals, we're so busy. Actually, busy is not the right word, but we're moving things so fast. And, I think you'd be crazy not to mention that as a factor for errors in the hospital. I'm sure people on this call know this better than me. But some hospitals, not mine, fortunately, but I work at hospitals or have friends that work in hospitals where you walk in, you get assigned 16 to 18 patients that you don't know. And to me, that just is amazing to me. And then I actually, again, maybe this is my bias as involved in medical education, but I don't see this as particularly being on the radar for medical residents. And organizations like you undoubtedly have had maybe 10 years of working on this for educating people. And I think that's a great thing. It has not gotten as much traction in my program as I would like it to eventually. And I can imagine there's a lot of ways this could be integrated in medical education that, at least in my neck of the woods, is not yet.
I would just like to respond to that. I can really connect with all of those. I mean, I wholeheartedly agree with all the 3 things you mentioned. And one comment on the memorizing differential diagnoses, I think that's ludicrous and crazy to try to do that. It would be like asking a pilot to memorize their pre-flight checklist, which thank God they don't do because they know that memories are fallible. And unfortunately, physicians haven't learned that yet. And so instead of reviewing a pre-flight checklist before our patient flies out of the hospital or flies out of the emergency room, we should be reviewing a checklist of the differential diagnosis for the complaint that they came with. I think we literally play a game when we're talking to residents or other physicians. Well, what's the differential diagnosis? Well, if you pulled out a list from your pocket, you would be seen as cheating, whereas we don't accuse pilots of cheating. We consider that a safety thing, and yet in medicine, it's like we're oblivious to that. I think it's a terribly unsafe practice to try to memorize differential diagnoses and go by that. So thank you very much. I think it's a great list. The 3 things you gave us, it's a tremendous list. I should put it up on my bulletin board.
Thank you very much. I agree with you. I never thought about it. I actually do think there's a role for, having rigor in education and, learning and, in fact, memorizing to a certain extent. But you're right. I never thought of it that way. I think it's because we come from a background of test takers. We're good at taking tests. We memorize things. We're like machines about it. But, when it really comes out to it, that those things are certainly not perfect training methods by any means. You learn that pretty quickly in the real world, though.
Could I just ask a quick follow-up on the preventability question, Craig? You mentioned that most of the diagnostic errors were preventable, such that your results ended up the same, whether it was preventable or not. But in general, was that a preventable in terms of the diagnostic error or preventable in terms of the harms? Because those are obviously 2 different determinations, right? If you can prevent you failed to order the colonoscopy that diagnosed the colorectal cancer or whatever, that's a preventable diagnostic error. But if that patient had 2 months to live because they had terminal lung cancer, the harms weren't preventable. Can you just talk a little bit about that?
Yeah, my guess would be that would, based on the methods of these studies, typically the harm part of it would not explicitly factor into their determination of preventability. And they would probably still count it as a preventable thing, at least playing by the rules. But all these are using implicit judgment. And as I think I showed, only about half of our studies actually had a specific description of the training for the physicians that were making these decisions. And so there's probably a lot of gray, and I wouldn't be surprised. And also variation, as I've talked about, with imperfect inter-rater agreement. So my guess, I wouldn't be surprised if people would look the other way for somebody who has hospice criteria already, then has some kind of medical error. I wouldn't be surprised if the average reviewer would downgrade that in terms of whether they'd count it as an adverse event or whether they would count it as a preventable adverse event or not.
That makes a lot of sense with the data that you described, because essentially what happened was all of them were preventable. They've already sort of crossed off their list anything that, they sort of subtly threw the hospice patient under the bus in terms of the diagnostic error and said that's not a diagnostic error. And they didn't gauge the preventability of the harms the way they might in, say, an autopsy study with the Goldman criteria, class 1, class 2, 3, and 4, where they're trying to gauge whether it would have changed the outcome. They focus just on whether the error itself was preventable. That then fits with your findings.
Are you trying to wonder how you would have, because I have to say I thought this myself. I had maybe somebody on this call would be able to explain this to me. I wasn't sure what a non-preventable diagnostic error would mean. Like, yes, you made a diagnostic error, but don't worry, it would have happened to anybody, I guess. I guess that's what it was. I guess if something is presenting so atypical, they're willing to give someone a break. I guess I answered my own question on it.
Yeah, that's what John said earlier, right? He listed the sort of quote unquote no fault errors. You know, it was too
I
early
see.
in the
I
presentation,
see.
it was too
Yeah.
rare, it was too atypical a presentation. That's the only way that it could be preventable conceptually. It's only the other it could not quote unquote not be preventable. Otherwise, they're
Yeah.
all almost by definition preventable.
Yeah. It's interesting. I never thought about it that much, but or to that or that related issue.
We've come to the end of our time. I'd like to thank Dr. Gunderson and everyone who joined us today. Our next journal club will be in September, and as always, we welcome any recommendations for those upcoming sessions. Thanks everyone for joining us. Take care.